Welcome back to the Curbsiders. I'm Dr. Matthew Watto here with my great friend, Dr. Paul Nelson Williams. We are going to be talking about some updates, really medications for CKD, Paul, right? With our favorite guest, everyone's favorite Curbsiders guest, Dr. Joel Topf. I mean, he's been on the show 20 times. This time we were talking about some of the newer meds that primary care doctors should be familiar with. Paul, SGLT2s, who owns these things? Is it the
Yeah,
cardiologist?
SGLT2s, good, great meds is what I hear. Yeah, I think what one of the points that kind of came up that Dr. Topf made is he thinks that someone needs to take ownership of these medications because they have such potential in so many different domains. They're great for heart failure. They're great for progression of chronic kidney disease. They're diabetes medications. So the question is who fires them off and who should be in charge of them. And so as two primary care doctors, I think we agree this is a medication that should be solely in the domain of primary care. I mean, maybe solely is overstating it, but this should be ours, Matt. This primary care doctor should
Yes.
be running the show.
Solidly in our lane. I
Yeah,
agree.
in terms of how to monitor and when to start and who's appropriate for it and how to counsel, we should be comfortable with all those things because they're great meds. And I think if we wait for a specialist to pull the trigger, it may not necessarily happen. So I think that was sort of the overall takeaway that I took from this. I'm not sure about you.
Well, Paul, I'm lazy and I'm a coward, so I don't want a medicine that's a lot of work for me. So what about these SGLT2s? It seems like I'm going to have to do a lot of monitoring. I'm going to have to really coax the patient to keep taking these. What did Dr. Toff tell us about that?
Masterful setup. Yeah, he's there. He said, "Don't be scared," which I think is right. And like as these medications have been looked at, they sort of keep decreasing the GFR that they're actually looking at in terms of safety outcomes. And I think they've been as low as 20 most recently. So like I think we feel pretty comfortable starting them in fairly advanced CKD. And even though you might see an increase in the creatinine, Dr. Topp's takeaway is you don't need to check unless the patient's reporting symptoms or feel like they're not tolerating it. So you can just sort of set it and forget it after you've maximized their other therapies. The caveat being they should be stable on their other medications. So if you're making a lot of wild diuretic adjustments, that's maybe not the time to fire it off. But otherwise, if you have someone who's stable and you're like, it's time to add one of these things on, you don't necessarily have to check 4 to 6 weeks after the fact. It's not going to change all that much of what you do because they don't cause that much changes in potassium levels. And even though you see
Right.
in creatinine, it's not going to really change all that much in terms of management. So you can just sort of fire it off and just the next time you check labs, just check and make sure they're actually taking it.
Yeah, set it and forget it. So it's not like when you start an ACE inhibitor or diuretic where typically it's always been my practice to check in a couple weeks to make sure things are going okay. You don't have to do that with this. And this EGFR, using these down to an EGFR or initiating them down to an EGFR of 20 is standard. And then he said in the trials, even if the patients ended up on dialysis, they were continuing the medication.
Yeah.
So, and I looked up on clinicaltrials.gov before this recording. There are ongoing trials in renal transplant recipients and in patients on peritoneal dialysis who have residual renal function. So we'll have probably an answer in the next few years about just how low we can go with these, Paul, if you will, which I think will be very valuable information. But right now, you can continue them even if somebody is on dialysis and they're tolerating it okay. And then, Paul, the one time that I think we should shy away from using them, and this has been consistent, Dr. Colburn, Dr. Toff, a bunch of experts have mentioned the same thing. If the A1C is above 10%, if it's in double digits, you kind of worry that person might have a lot more osmotic diuresis, be more prone to hypotension and maybe bad outcomes. So we don't necessarily use them as much in those cases, but that's really it. And maybe increased risk for euglycemic DKA if that's a patient that's like, doesn't have enough insulin. But that's kind of my practice. I don't know if yours differs.
Yeah, it's right. If they're in double digits, I try to shy away. Just for those exact reasons. Then also, I do see, at least anecdotally, sort of more of the mycotic infections that we talked about during the episode. So I think just sort of, I'd rather have them a little bit better controlled before I fire it off. So they don't have to be perfect, but they at least not double digits is my personal practice.
We also talked about these are weaker agents for actual control of diabetes. They were initially brought on as agents for diabetes, but when they were testing them for safety, they realized that they're not only are they safe, they're like good for the heart, they're good for the kidneys, and now they're essentially heart and kidney medications. And diabetes is more of an afterthought for the most part with them. So, well, Paul, let's talk about another this really is a newer agent. The SGLT2 inhibitors have been around for like 10 years.
Yeah.
But finerenone, that's one that I keep forgetting the name of it. It's that new. I don't know if that's I know we spent a lot of time talking about it in the past few months, but I actually, when I was refreshing myself, I was like, oh my gosh, I'm like having trouble recalling the name of this. So it is new, and it's a non-steroidal mineralocorticoid receptor agonist. So antagonist rather. So think of like it's spironolactone kind of, but a different chemical structure, but it's mineralocorticoid receptor antagonist like that. Paul, have you seen this in the wild yet?
No, it's funny. I have not forgotten the name because I can't remember if I said this on the show or not. One of an amazing endocrinologist that I worked with is like, have you considered finerenone for this patient? I was like, not only have I not considered it, I had never even heard of it before. So I was so ashamed of that I then aggressively looked it up. So that it's now, the name at least is locked in. It's not one that I fire off, and I'm right now at the point where I would probably save it for a specialist. If someone's kidney functions to the extent that I'm thinking about it, probably it should be managed by a nephrologist at this point in any case. So that's not something I see very much.
So the patients you might think about this in, because this is all we'll have time, but you'd have to listen to the full episode to get into the full nitty gritty of this. But essentially, patients with diabetes and CKD, if they're on renin-aldosterone inhibition, like an ACE or an ARB, and those are maxed out, they're on an SGLT2 inhibitor, and they still have albuminuria, think about starting finerenone to further prevent progression of their kidney disease and help reduce the albuminuria. The trials of this, Fidelio, DKD, Paul, they did actually reduce major adverse kidney events, or MAKE, Paul, in
Great
that
stuff.
trial.
Yep.
Which in the past, they've tried that with spironolactone. They weren't able to do that. But Dr. Topf made the point that, if he was choosing between spironolactone and this, spironolactone is better for controlling blood pressure, and with both of them, you just have to worry about hyperkalemia, which was even in really heavily selected, very carefully selected patients, some of them on therapy to lower potassium, hyperkalemia was a problem in the trial. So you got to watch out for that. Any other words on this, Paul? Before I think we've covered a lot in this short video, and people should definitely check out the full episode.
Those are the words that I would say.
Okay. All right. Well, this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. Paul?
You got it, Matt.
All right. Until next time, I've been Dr. Matthew Frank Watto.
And I remain Dr. Paul Nelson Williams. Thank you and goodbye.